Welcome to the Falls Mini Didactic. I'm Dr. Steve Barzey, a geriatrician and clinician educator who works within the Madison VA Geriatrics Research, Education, and Clinical Center and also within the University of Wisconsin Division of Geriatrics. And I'd like to introduce some key principles that relate to falls and specifically emphasize that falls are a big deal. They turn out to be one of the key reasons why a lot of our older patients end up losing function and ultimately possibly ending up within nursing homes or worse. And many people have this perception that falls are inevitable. And once a person has started falling, there's no way we're going to keep them from falling again. And this is an error in thinking, and we miss a great opportunity to help our patients. But back up for a moment. Falls are one of several key geriatric syndromes, and it's very important for any clinician to be comfortable in knowing how to assess, potentially identify the risk, whether a person might be low, medium, or high risk, and ultimately to provide feasible and practical interventions that can reduce the chance for future falls. In this session, I'm going to zip through a bunch of principles that I think are very important that come from evidence-based practice, and specifically I'd like to go over with all of you the learning objectives for this session. Specifically, there are some amazing resources out there, and I think it's important that all clinicians know some of these resources so they can go to them when they need to. The Geriatric Scholars Toolkit has a number of important elements that can help with assessing for falls. The CDC STEADI website, that is STEADI, which stands for Stopping Elderly Accidents, Deaths, and Injuries, has a number of resources both for patients as well as for providers. Next, I'd like to walk you briefly through some key historical details that make all of us detectives as we are sorting out what happened and where it might have occurred, when the fall occurred, and what injuries might have occurred. A lot of the W's. And finally, through the CDC algorithm, highlight certain key interventions that we know reduce risk for future falls and ultimately may help our patients to prevent disability and prevent loss of independence. I mentioned that falls are a big deal. And what I meant by that is really a big deal. If you look here at a statistic that's published within the CDC website, we see an upward trend in falling in approximately a 1-decade period. Now, is this really that people are falling that much more often? It may be, too, that our ability to report and recognize falls is improving. We know that the scrutiny about falling in the hospital and falling in pretty much any healthcare center has become a big deal. We also know that approximately between 1 in 3 or 1 in 4 older adults will fall each year. And then if you go into special populations like individuals living within assisted living or nursing homes, that number is much higher. About 1 out of every 5 falls leads towards serious injury. And by that I mean broken bones, head injury, or death. This leads to a large number of emergency room visits every year. And it leads to a lot of hip surgeries and also to a substantial cost to the economy, to the order of conservative estimates of $50 billion per year. So this puts it in one of the big ticket costs within the entire healthcare system. So we know it's a big deal, but what can we do about it? And that's where going to some of those resources I talked about can be very helpful. First, I'd like to walk you through some of those resources that I had referred to earlier. If you go to the CDC website, that is cdc.gov/STEADI, it'll bring you to this page. This page is a great initial portal that provides you with resources that you as a provider can access, fact sheets, case studies, some very useful pocket cards, and algorithms. And I'm going to specifically go through the algorithms momentarily. But there's also some really valuable resources available for patients and family members, as well as some teaching tools that you might use with some of your colleagues. So going to the Materials for Providers site, that there are a number of valuable resources, as I mentioned, but I want to bring you first and foremost to that algorithm for fall risk screening, assessment, and intervention, which I find to be a very valuable resource and something you can go to quickly. So if you're tracking here, right at the very beginning of this algorithm, it gets into a questionnaire that you can administer from the CDC site, but probably more importantly, over in the box here under key questions for patients. These 3 questions are the questions to ask. And these are the types of questions that over and over again we emphasize to all of the providers in our practices. Is a person feel steady when walking? A sense of imbalance substantially increases one's risk for falling. So, do they feel unsteady when standing or walking? Number 1. Number 2, is there a worry or a fear that they have for falling? The fear of falling is a big deal. And lastly, have they fallen in the past year? It turns out a fall in the past year increases one's chance for future falls. 2 falls in the past year is a big red flag. And I want to drive home that just asking the patient the question, have you fallen, may not be quite as effective as using a normalizing statement such as, when was the last time you fell? And you might insert in there, I fall, everyone falls. So when was the last time you fell? If they've fallen, the 2 most natural next questions are, as I mentioned, how many times in, say, the last year? And then, was there injury? Because 2 times or any falls with injury raise the stakes for a person to be in a much higher risk category. So if they respond yes to any one of those, so once again, do they feel steady on their feet or not? Do they have a fear of falling? And if they have fallen, and especially 2+ times or falls with injury, then they demand further assessment. If someone doesn't respond to any one of those 3 questions, they still are at some increased risk for falling, and so if you look over here for the screened but not at risk, you can see that we still would be educating patients about the consequences of falling. We would potentially be exploring what their vitamin D levels are, because, as I will emphasize, vitamin D not only plays a key role for bone health, but also for muscle function and balance too. And depending, especially if they're somewhat frail, or you just have a gut feeling that they could fall in the future, engaging the patient to find a community exercise or fall prevention program, and there are many within the communities, especially within senior centers and area agencies on aging. If your patient has screened at risk, then I'd like to direct you to this middle column here, which specifically identifies a number of contributing factors that could be causing that person's falls risk. And here's where I want to take a sidebar moment and emphasize that geriatric syndromes, by definition, are almost always multifactorial. And then, as we'll talk about a little bit later, the interventions that we provide are often multifaceted. So, looking in this middle column, if you find one or maybe even two explanations for this particular patient's falls, don't stop there. Really be systematic. Consider that there could be 2, 3, 4, or more contributing factors. And really only by identifying all those factors can we intervene and increase the person's chance for having less falls and potentially less catastrophic falls in the future. So I'll allow you to take a moment here to just take a look at some of these common causes which we should be thinking about as we're sorting out what might have led to an individual's specific fall. And here I want to point out or emphasize a couple things. Medications, medications, medications. Okay. In general, the answer to almost any geriatric syndrome as to why it might have occurred will have medications in the sentence. We know that there are a number of prescription agents, but there also are a host of over-the-counter agents that we might not ask about, and patients don't automatically offer them up. So it's very important that as we are discussing medicines that we explicitly sort out, are there over-the-counter supplements or OTC meds that a person might be taking. In the same vein as medications are substances. And certainly alcohol, marijuana, and other illicit substances can be used by older adults. So medications and the subtitle of substances, don't forget to ask about these issues. It's also valuable to think about vision. And there are lots of reasons why vision can be a significant and risk factor. But what I want to point out are low vision alone does have some role, but distortion or change in depth of vision, meaning that visual acuity might be better in one eye than another, is an even bigger deal. Loss of depth perception is huge if a person has poor vision in one eye but not both. Having a big cataract in one eye versus both. And then there's the iatrogenic aspect of a person with a visual problem. That we may, or more likely, an optometrist may have provided bifocals or graduated lenses. And bifocals or graduated lenses are a great way to fall down. Let's think about it. As you look through that focal point down towards your feet, that's where you see this distortion. And so you don't really exactly know where your foot is going. And so you take someone who has several other risk factors and then you put bifocals on them, and it's a recipe for disaster. So don't forget to ask about bifocals. As we continue to explore things, don't forget about the home and home environment, or more specifically, home hazards. And it goes beyond the standard throw rugs and clutter on the floor. and the risks of falling in slippery spaces such as bathrooms, to understanding how many steps a person has going into the home, how many steps do they have to navigate in getting around through their day-to-day life, what's the lighting like, especially the lighting at nighttime, are there grab bars or other things, railings that can be used for patients as they navigate around if they are a bit unsteady on their feet. There's a lot more to a home safety assessment than what most of us as practitioners can address in a single visit. And that's the beauty of a team. As I mentioned previously, teams are a pivotal role for caring for complicated older patients. And engaging teams such as occupational therapists or physical therapists to be part of the solution is a very logical and also an easy way to share the burden for helping a patient out. As I mentioned, let's not stop there though. And so again, as you track down this middle column, you see other pretty logical things that could be contributing. Orthostatic blood pressure, potentially from medications or maybe from diabetes with dysautonomia. Issues that might be affecting a person's gait, their feet, pain in their feet, bunions, calluses, exploring the status of the vitamin D, which as I mentioned before, plays a very key role for muscle function as well as balance. And once we've thought about all of these different contributing factors, then we need to do something objective. We need to have some dimension of an examination. And with regards to the examination, it's valuable to be able to observe a patient arise out of a chair. Do they use their arms? Can they push off on their own? When they first stand up, do they look steady or do they have some wavering? And then observe their gait. Now, there are different ways you can do this, and as listed in this protocol here, the STEADI protocol, under common assessments, the timed up and go or get up and go is something that many of us use. It's a place where a person will sit down on a chair, stand up, walk 10 feet, turn around, come back, sit down. If you want to make it quantitative, then you can actually time it. Or you can do a 4-stage balance test. But wait, what is a 4-stage balance test? Aha, and that's where the resources on the Geriatric Scholars community website and specifically within the toolkits can be very valuable. So right now, we are in the toolkit under the Falls category. And so I'll orient you for a moment. You can see that within the Falls toolkit, there's a general overview. There is a nice pocket card, which I'll come back to a little bit later. But then, aha, we see the 4-stage balance test listed here. So clicking for that, we can look and see exactly what we're talking about. So this is just a 4-step maneuver, and you have a patient put their feet together, and you observe them ideally for 10 seconds. If they're able to do that, then you have them stagger their feet one slightly in front of the other, which becomes a more difficult task. Again, for 10 seconds. If they're able to do that, then we move to the tandem, that is the tightrope. And this is where a lot of our older patients fail. They have a tough time doing this maneuver. But a few may be able to do it. And if that's the case, then we have them stand on one foot. And we can document at what point they have difficulty in one of these 4 stages. So moving back, as I mentioned, to the algorithm, although not listed here, many people might do something such as a Romberg also. So you've observed their gait, you've done some measure of balance, whether it be the 4-stage balance test, the Romberg, or possibly both, and now it's time to intervene. So this is where we're in this far right column. And as you can see, tracking down every one of those risk factors that I mentioned before has a potential intervention. So there's a long list here, and this may be more than many people can tackle in a single intervention. So if we were to rank order the priority or the degree of yield of these various interventions, we've identified potentially several different factors contributing because, of course, all geriatric syndromes are multifactorial. And we're going to now try to figure out what can we do next. What might we be able to do to reduce a person's risk for future falls and ultimately improve the quality of their life? In this box here, you can see a number of different factors that we've already talked about and how each one of those factors has several things that we might be able to offer up. But we might not have the luxury of being able to go through all of these with every patient. So in this case, it's important for us to prioritize what are some of the high yield interventions, the things that you might do first as you're working down the list. Most of us, again, would emphasize that adjusting medications can be a quick and potentially high yield intervention. Equally, because many of our patients are having problems with strength, with gait patterns, with balance, considering a referral to physical therapy and/or to certain exercise and balance-based, evidence-based practices such as Tai Chi could be fairly high yield. And then remember I mentioned about the bifocals, or more specifically about various visual distortions that can influence how well a person navigates around the home, navigates up or down steps, and the like. So many people will consider those things first. Now, you might be able to systematically move through and pick off more than just that list. But in many cases, I will emphasize to patients that this is a multifactorial process, and I've got a list of things that we can work on, and let's work on these few things first so we don't overwhelm the patient. When you are offering up these multifaceted interventions, don't forget to write things down. Even if a person seems to be cognitively intact, there's only so much that any of us can take in at any one time. So consider a multifaceted approach, engaging a team. Don't feel like you need to do this all on your own, and emphasize to the patient and to family that these things can and do make a difference. But wait, I didn't want to forget about the home hazards and the home environment. And in a perfect world, everyone would be able to get a home safety assessment as soon as they've had a fall. But sometimes Medicare and other insurance payers don't allow that. Now, the VA is a wonderful place, and in many situations we can get a home safety assessment if there is a veteran who is part of the system. That again is where we reach out to our team members. So I want to kind of drive home the point that falls are a big deal, but we can do something about it. At the risk of being repetitive, maybe even obnoxious, I'd like to drive home one last time that falls are a serious threat, a big deal that can be the difference between a person being independent and not being independent. Falls can, with a systematic approach that includes being a detective and then relying upon assessments that are standardized, and finally providing a multifaceted intervention plan that will include multiple team members. This is the way that we can really help our patients and address this potentially complicated geriatric syndrome. So I want to try to motivate all of you to think about falls a little bit differently than what you've done before, and use these evidence-based practices, use the resources available through Geriatrics Toolkit as well as through the CDC STEADI website and make a difference. Thank you.